Hello, welcome to the Clinical Care Options Neuroscience podcast series called The Future of Brain Cholesterol Turnover for Neurologic Diseases. This podcast series is supported by an independent educational grant from Takeda Pharmaceuticals USA Incorporated. The focus of this podcast is assessing the efficacy and safety of emerging strategies that impact brain cholesterol turnover. I will be your host. I'm Dr. Jonathan Halford, and I am a professor of neurology and an adult epilepsy specialist at the Medical University of South Carolina in Charleston. Today, I have the pleasure of speaking with Dr. Cecil Hahn, who is a professor of neurology and a pediatric epilepsy specialist at the University of Toronto in Ontario. Before we begin, I have a quick housekeeping note. This episode is accredited for 1/2 of an AMA PRA Category 1 credit, and also for ANCC contact hours. After listening to this podcast, please click on the link in the show notes to take the post-test and earn your CE or CME credits. All right, let's get started. Dr. Hahn, it's a pleasure to speak with you today.
Pleasure speaking with you as well, Dr. Halford.
We'll be talking today about developmental and epileptic encephalopathies, and also about a new class of antiseizure drugs, which is being tested to help decrease seizures in these patients. Developmental and epileptic encephalopathies, we'll call them DEEs for short during our discussion, are a group of conditions characterized by developmental delay, cognitive impairment, and frequent epileptic seizures. Dr. Hahn, could you tell me more about this group of disorders?
Well, in DEEs, cognitive impairment or developmental delay is thought to be influenced by the underlying cause of the epilepsy, but also the seizure activity and the epileptiform discharges or abnormal electrical activity in the brain. People with DEEs often have multiple different seizure types, which are difficult to control despite the use of multiple anti-seizure medications.
What causes DEEs?
There are actually many different causes, including genetic variants such as Dravet syndrome, metabolic disorders, acquired brain injuries such as cerebral palsy or infections, brain malformations such as cortical dysplasia or tuberous sclerosis complex. Some of these patients also develop Lennox-Gastaut syndrome, which is a characteristic type of epilepsy with multiple different types of seizures and certain EEG findings and cognitive impairment.
Wow, that sounds like a lot of causes. Why are so many patients with so many different causes of seizures all grouped together in one disorder? What are the symptoms of patients with DEEs, such as Lennox-Gastaut syndrome? What symptoms do they share in common?
Well, patients with DEEs, in particular Lennox-Gastaut syndrome, have their seizure onset in childhood, usually between age 3 and 5 years. And they usually experience seizures of multiple types, including so-called tonic seizures, generalized tonic-clonic seizures, also called grand mal seizures, absence-type seizures, atonic or drop seizures, myoclonic seizures, and even focal seizures with impaired awareness, epileptic spasms, and some develop a condition called non-convulsive status epilepticus. Intellectual disability is also a hallmark of Lennox-Gastaut syndrome, and this can get worse over time. And sometimes these patients have behavioral challenges, such as aggression and hyperactivity as well.
Are there tests that can help us diagnose Lennox-Gastaut syndrome?
The most helpful test really is the EEG, which shows a slower background rhythm than expected for age, and a characteristic pattern called slow spike and wave activity and paroxysmal fast activity. A brain MRI is also helpful to understand the underlying cause, such as a structural abnormality, such as the tubers of tuberous sclerosis or a cortical malformation, or to look for evidence of prior brain injury. Genetic studies should also be done, including chromosomal microarray testing and an epilepsy gene panel.
Are there other causes of DEEs besides Lennox-Gastaut syndrome?
There are many other types of DEEs, and we're learning more and more about the causes of epilepsy as we're discovering more and more genes associated with epilepsy. Some conditions start even younger than patients with Lennox-Gastaut syndrome, so within the first year of life, and some have a very clear genetic cause. One of the most common of these is called Dravet syndrome, which is due to a gene mutation in SCN1A, which is a sodium channel gene. And seizures with Dravet syndrome usually begin in the first year of life and often happen during fever. So they're called febrile seizures, but they last quite long, often more than 5 minutes, and often involve one side of the body or the other side of the body. But children with Dravet syndrome usually develop multiple seizure types as well. And their development, although it can be normal in the first couple of years of life, often begins to slow, and they begin losing their developmental trajectory, slowing their trajectory as they grow older. Although there's a wide range of severities, and some children with Dravet syndrome can have near normal intellectual ability. Some other patients with DEEs have something called early infantile epileptic encephalopathy, where seizures start within the first few months of age. And this is also generally caused by a number of different variants in epilepsy genes or by metabolic disorders.
Are there any treatments for the underlying problems which cause DEEs?
Well, rarely there are specific treatments for the underlying cause. Usually in children with metabolic disorders, certain vitamin therapies can be prescribed. But unfortunately, for most DEEs, there's no specific treatment yet for the underlying cause. And so the focus really is on treating the seizures. And a number of anti-seizure medications can be used, but often seizures are difficult to treat and seizure freedom may be hard to achieve.
So are there certain anti-seizure medicines that should be avoided in certain patients with DEEs?
Well, there are sometimes specific treatments to avoid. So for example, in children with Dravet syndrome, we know that certain sodium channel blocking medications can actually make seizures worse. So medications like phenytoin, carbamazepine, lamotrigine are often avoided in patients with Dravet syndrome or some of the other early infantile epileptic encephalopathies.
So why are the seizures in DEEs so difficult to treat? And I know that some patients with other types of epilepsy do have difficult to treat seizures, but it seems like a large portion of patients with DEEs, the seizures are difficult to treat with anti-seizure medicine. Is that correct?
That's correct, and that's a really good question. The short answer is we really don't know why seizures in DEEs are not very responsive to anti-seizure medications. But the right combination of anti-seizure medications can help to decrease the frequency of seizures, can make seizures less severe, and that can reduce the degree of cognitive impairment and improve quality of life.
So what are the typical anti-seizure medicines that are used for patients with DEEs? I know this varies somewhat between the different causes, but tell me briefly about what's usually used as first agents.
So as you said, it varies somewhat between the different DEEs, but in general, the first-line therapies are usually medications like clobazam or valproate, especially in children with Dravet syndrome. Those would be considered the first line, and we have some good guidelines to help guide treatment in specific conditions like Dravet syndrome. Sometimes the second line treatment is the addition of topiramate, or in the case of Dravet syndrome, a medication called stiripentol. And after that, there really are multiple other medications which can be used, including grapheniramide or cannabidiol and any other number of medications. Sometimes the choice of medication is guided by the type of seizure that you're trying to control, or also to minimize drug-drug interactions.
How many combined anti-seizure medicines do you typically use in your patients with DEEs?
Well, I always try and minimize the number of anti-seizure medications because as you add additional medications, you increase the complexity, you increase the chances of side effects or drug-drug interactions. But inevitably, it's more than one, and usually 3 or 4 anti-seizure medications. And sometimes a combination of medications at lower doses can be more effective. We think that sometimes medications have synergistic effects. Really, it is unfortunately still a bit of trial and error to find the right combination for the right patient.
So which drug combinations do we suspect there might be a synergistic effect in treating these disorders?
Well, I would say that we think about something called rational polypharmacy. That's a term that epileptologists use when they try and think of medications that have different mechanisms of action that you could combine. For example, sodium valproate is a medication that we know acts on calcium channels. And sometimes you could combine that with clobazam, which acts on GABA receptors. It's a GABA agonist. And so that combination of medications might have synergistic effect.
What sort of non-pharmacological treatments are there for patients with DEEs?
Well, the main non-pharmacological treatments that we consider are the ketogenic diet, which has been shown to help patients with both Lennox-Gastaut syndrome and Dravet syndrome, for example, and the vagus nerve stimulator, which can help patients with a wide variety of different types of epilepsy, including developmental and epileptic encephalopathies. Occasionally, we consider epilepsy surgery, particularly in children with either focal seizures due to, for example, tuberous sclerosis or cortical malformation. And in children who have drop seizures or seizures where they fall, sometimes we consider an operation called a corpus callosotomy, where there's actually a division of the two halves of the brain to prevent seizures from spreading to both sides and causing a fall.
All right, thanks. So I understand that you have been one of the investigators recently involved in helping to develop a new type of drug called a cholesterol synthase inhibitor for the treatment of seizures in patients with DEEs. You were recently a first author on a scientific paper which reported findings from a clinical trial of this drug. So why a cholesterol synthase inhibitor? When I think of cholesterol, I think of atherosclerosis, heart attacks, and strokes. How is cholesterol involved in brain function?
Well, we've learned a lot about cholesterol and heart disease over the years, and we think of cholesterol as having something to do with hardening of the arteries or atherosclerosis. But cholesterol is actually a critical component of cell membranes throughout the tissues of the body, and in particular, nerve cells. The cholesterol is found in a higher concentration in the brain and the spinal cord relative to the rest of the body because it's part of the insulating sheath of nerves, myelin, which improves the speed and efficiency of nerve conduction.
So how did researchers come upon the idea that cholesterol might be linked with seizures?
Well, we don't have any direct evidence that cholesterol metabolism in the brain causes seizures, but because cholesterol was found in such high concentrations in the brain, it was studied as a potential cause or factor in many different neurological disorders. For example, there's been research studying whether cholesterol metabolism could be related to Alzheimer's disease or other neurodegenerative diseases. And we know that cholesterol metabolism can alter brain signaling, in particular with the N-methyl-D-aspartate or NMDA receptor, which is the most common excitatory neurotransmitter in the brain. And we know that changing cholesterol metabolism can affect glutamate levels in the brain, and glutamate is the main excitatory neurotransmitter in the brain. And we know that NMDA is important in the generation of seizures. And so I think this is what motivated further study of whether altering cholesterol metabolism could help treat epilepsy.
So you've been involved in studying a medication which affects cholesterol metabolism, may decrease seizures in patients with DEE then. This was a clinical trial involving a medication?
That's right. I was one of the investigators for a phase 2 clinical trial called the ELEKTRA study of this medication called soticlestat, which is a selective inhibitor of an enzyme called cholesterol 24 hydroxylase, which is actually specific in the brain. And this enzyme breaks down cholesterol in the brain and catabolizes it to 24S hydroxycholesterol or 24HC. So in animal models, in a mouse model, it was shown that soticlestat treatment actually lowered brain 24HC levels and suppressed the elevation of glutamate levels, extracellular glutamate levels, resulting in reduced hyperexcitability in the brain. And that is thought to potentially decrease the propensity for seizures.
Great. So what types of patients were included in the soticlestat clinical trial?
So in the ELEKTRA phase 2 study, in order to qualify for the study, participants needed to have a diagnosis of either Lennox-Gastaut syndrome or Dravet syndrome and a history of not responding to multiple antiseizure medications. They also had to be having a relatively high rate of seizures. In patients with Dravet syndrome, they had to be having at least 3 convulsive seizures per month leading up to the study. And in those with Lennox-Gastaut syndrome, they had to be having 4 or more drop seizures per month. That is, seizures that would cause a fall.
So drop seizures were the primary outcome measure in the Lennox-Gastaut part of the study?
That's right. So as we've discussed, patients with Lennox-Gastaut syndrome and Dravet syndrome have many different seizure types. And some of these seizures are more disabling and some are more subtle. Some are easier to measure, easier to quantify than other seizure types. And so when designing a clinical trial, we try to pick an endpoint or a target for therapy that's both clinically significant, that's disabling, and also feasible to quantify. And that's why drop seizures have been an endpoint in many different anti-seizure medication trials, including this particular trial for Lennox-Gastaut syndrome. Other seizures that were targeted more so in both arms, but especially the Dravet syndrome arm, were the generalized tonic-clonic seizures, the so-called grand mal seizures, or other clonic or tonic seizures. And so we try and pick an endpoint that's both clinically significant and that's countable.
Great, thanks. So what other types of information was collected in this study?
So this was a randomized controlled trial. So half of the study participants received the study medication, soticlestat, and the other half received the placebo or sugar pill. And it was randomized, so both the investigators and the participants were unaware of which treatment they were receiving. So during the first phase of the study, so-called baseline phase, caregivers recorded the type and frequency of seizures. And then there was the active treatment phase, during which they continued to record seizure frequency, and the patients received either the study drug soticlestat or placebo. And that was for a period of 8 weeks, dose optimization, and 12 weeks maintenance period. And during the dose optimization period, the medication or placebo could be titrated up to what was considered an effective and tolerated level. And then afterwards, there was a follow-up period of 4 weeks. And then subjects had the option of continuing on in what's called an open label extension study, where they all received the study medication soticlestat.
How many patients participated in the study?
So there's 139 participants, 51 with Dravet syndrome and 88 with Lennox-Gastaut syndrome.
Did you see any effects from the medication on the frequency of seizures?
We did. So we saw an effect in a number of different ways. So the main outcome measure for the study was the median reduction in seizure frequency, placebo adjusted, so between the study medication and placebo. And in subjects with the Dravet syndrome, the placebo adjusted median reduction in seizure frequency was 30% during the maintenance period. Whereas in Lennox-Gastaut syndrome, the placebo adjusted median reduction in drop seizure frequency was 17%.
So that's very interesting. There were statistically significant results. That's exciting for a phase 2 study, right?
Yeah, so what we found was that in children with Dravet syndrome, the reduction in seizure frequency when compared to placebo was statistically significant. In patients with Lennox-Gastaut syndrome, there was a reduction observed in seizure frequency, but it did not reach statistical significance. And we have thought about why that might be. And one of the observations was that the seizure frequency in patients with Lennox-Gastaut syndrome varied considerably. And so there was a lot of variability in the baseline seizure frequency. And when you see that in a clinical trial, it can be more challenging to demonstrate a reduction in seizure frequency in a clinical trial setting. But I would say that because of these phase 2 study results, the study sponsor felt there was enough evidence to proceed with phase 3 clinical trials, which are currently underway in both Lennox-Gastaut syndrome and Dravet syndrome.
Well, that's exciting. Thanks for explaining that. Were there any other changes in the patient's overall level of functioning as rated by their caregivers?
Yeah, that's a very important question because, as you know, it's not just about seizure control, it's also overall functioning. And non-seizure symptoms are an important endpoint in these studies. So at the last study visit, caregivers rated patients taking the study medication to be improved in about 50% of cases, compared to about 30% of subjects taking the placebo.
Were there any side effects to the soticlestat medication?
Another important question. So we always look for side effects as an important outcome in clinical trials because side effects often limit the ability of patients to use medications. And so in this particular study, most of the side effects reported by caregivers were either mild or moderate in intensity, and caregivers of patients assigned to take placebo also reported similar side effects. The most common were lethargy and constipation, but there wasn't a significant difference between the side effects reported by the caregivers of patients taking the soticlestat medication versus placebo. So overall, it doesn't seem that the drug has any significant side effects, although, again, this is a relatively small study, short-term study, and we need larger numbers of patients and longer follow-up to understand if there may be rare side effects that we haven't yet seen.
Great. So you mentioned that there are other studies going on now with this compound. Are those going to be larger studies?
Yes, the pharmaceutical company which is developing soticlestat is currently conducting 2 phase 3 clinical trials of soticlestat, which are designed in a very similar fashion to the phase 2 study, except they're separate studies for Dravet syndrome and Lennox-Gastaut syndrome with larger number of subjects in both studies. And the first of these in patients with Lennox-Gastaut syndrome has just finished recruiting patients into the study, and the results are being analyzed now. And the Dravet syndrome study is ongoing and still recruiting patients.
Great, that's exciting. Well, thanks for talking to me today about this. Sounds like this drug holds promise for treating patients with DEEs, and will be interesting to see, if any side effects from this medication are detected. Many of our antiseizure medicines used to treat these disorders are associated with, considerable side effects, sleepiness, lethargy. So it'll be nice to have an option of a medication to add which doesn't add a lot to the side effects which patients have.
Yes, I think these kinds of studies are very important. Those of us who treat patients with developmental and epileptic encephalopathies struggle to achieve seizure freedom in these patients. So anytime there's the potential for a new therapy, we get very excited, and we hope that these phase 3 studies, which hopefully will provide results in the next year or so, will provide us with a new option for treating these patients with such often devastating epilepsies.